Fantastic. Well, thank you so much for being here, taking the time to spend your lunch with me to talk about a little bit about research and some of my passion related to measurement and mental disorders at the population level. Thanks, Kathy, very much for the introduction, and Catherine for our land acknowledgement. And today, so I'm gonna talk about surveillance in general, but the title of today's talk is One Piece at a Time: Building Surveillance of Child and Youth Mental Disorders and Associated Service Use in Canada. And I wanted to thank also everyone who's on the call virtually today. I know there's a few family members on the call, so that's always exciting to present to family members. Hopefully they don't ask any questions like in my, I was lucky enough to have questions in my master's and PhD thesis defense, so we can forego those today. Thanks. Awesome. So the objectives of today's talk, I'm going to try and answer a few questions. Why do we want to focus on surveillance? I'm going to highlight some current gaps in efforts being conducted for surveillance currently in Canada. I'm going to try and answer the question, how can we start to build surveillance? And I'm going to talk about a few descriptive key components that would go into developing surveillance, including factors related to data and measurement. And I'm also going to try and answer the question, what does the future of surveillance look like? And I'm going to provide a bit of information about one vision or one thought on what the future may look like. So to begin, we're going to define public health surveillance, and it can be defined as the continuous and dynamic process of observing a target in a specific population over time. And it consists of several processes, including ongoing data collection, analysis, interpretation, knowledge production, and timely dissemination. And the value of surveillance is that it really provides it's an essential component of quantifying disease burden in our population. And when it's paired with policy and programming, it becomes quite a powerful tool, which can be used to improve efficiency and effectiveness of health services by targeting interventions, documenting their effect on the population over time. And the goal of all of this, of course, is to generate knowledge to inform public health action, to reduce morbidity and mortality, and improve population health. Now, I don't really need to talk too much about the importance of child and youth mental health among this group. But why do we want to focus on surveillance for child and youth mental health in Canada? There's a few specific background information that's important to know. Specifically, the prevalence of mental ill health has been shown to be increasing among youth in Canada and globally. But also the perceptions of need for professional help for mental health has nearly tripled among children and youth between 1983 and 2014. And these types of findings come from the seminal work from the Ontario Child Health Study. And the Ontario Child Health Study is certainly home at Offord Centre. And correspondingly with the increases in perceptions of need for service use, evidence from service use research conducted in Ontario shows that there's been increases in service use across the board for mental ill health among youth in Ontario. And there's been notably increased elevated estimates of service use, particularly in acute care settings. But even though there's been increases in service use, our findings continue to suggest that the distribution of service use across child and youth population subgroups remain uneven. And so this unevenness leads to sort of disparities in mental health access and care to children and youth in our populations. And some of our evidence suggests that some of these disparities might be greatest among migrant populations, and we'll discuss this a little bit later. But despite these concerning trends, Canada has yet to establish a comprehensive national approach for surveillance of mental disorders and associated service use among children and youth in Canada. And myself and Kathy have written about this topic in a recent paper that came out in the Canadian Journal of Psychiatry, which discusses and outlines some of the background around surveillance, some of the current surveillance efforts that are being conducted, in addition to some gaps and also a vision for the future. And this opportunity to work on this project kind of arose from my CIHR funding. And honestly, it was a fantastic opportunity to work with colleagues from across the country who have had extensive experience in these topics and have worked in these areas for years. And so I just learned from each of them while working on this project, and it was honestly an honor. But one finding that we did sort of note throughout this work was that current surveillance or current evidence is really fragmented and it's disparate, and it reflects heterogeneity or variation in the data sources that are being used to measure mental health. And this includes both general population-based surveys and health administrative data. And for the most part, these data sources have been used sort of individually to conduct research and to deduce information about mental health, and there might be some limitations to that, and I'll reflect that later. Also, there's been heterogeneity in the geographical coverage of these different efforts, which have comprising evidence from local and regional, provincial, territorial, and national levels. There's also heterogeneity in the conceptualization and measurement of mental health, which include measures of perceptions of treatment need, symptoms, functioning, and diagnosis. Our team is very passionate about measurement of mental health, and so there's just a huge variety of unknown related to the approaches that need to be taken to try and best understand mental health, and so there's just a lot to be learned there. But current efforts are quite heterogeneous and variable. So a good example of some current surveillance available in Canada comes from the Public Health Agency of Canada, and you all might be familiar with the Canadian Chronic Disease Surveillance System. Or maybe not, but this is one of the most prominent surveillance type efforts that is conducted at the national level. And it's been going on for roughly 15 years now, I think even greater, but it synthesizes provincial and territorial health administrative data. And I'm going to talk a little bit more about health administrative data later, but this focuses on context to the healthcare system, particularly context with physician services. And so all the provinces aggregate findings about physician contacts, then they send it to the Public Health Agency of Canada, and it provides some trends in mental health service contacts. And so it ends up leading to some annual estimates of mental health service use across Canada. And if you go to the Public Health Agency of Canada website, we can find graphs like this, which show different prevalence estimates annually for child and youth, and there's subgroups of children and youth there. You can see the age strata, but it shows health services used for mental health. And this, I'm going to argue, provides quite a limited view of mental health among children and youth in our country. It's one important view, but it's quite limited. And to note, the same type of data is used by CIHR in their periodic reports on child and youth mental health. And similar data is also used in a surveillance effort that's led by primary care, which is called the Primary Care Sentinel surveillance system. And they use similar physician-based information to deduce information about population health. And so from our understanding of what's currently available at national levels, similar efforts are kind of conducted at provincial levels. And so for our sake, we experience that there's several evidence gaps that are currently existing in Canada. We currently lack the ability to really estimate the number of children and youth with a mental disorder. This seems like a question we should be able to answer, but we cannot. We also can't. We don't really lack ability to understand the number of children and youth who are seen by service providers for mental health related concerns that are inclusive of all different sectors that provide care to this population. And so not just focusing on physician context, but also context to other service providers. Particularly for children and youth, it's quite relevant to have some measurement of counseling that's being conducted in schools and in community centers. And these types of data are not captured in health administrative data currently. And so it's a huge gap in our ability to measure those who are receiving care for mental health. And then, we also want to really understand the reach and targeting of mental health services. And so we can't really currently measure in the population, those who have mental disorder or have a need for mental health services, the proportion of those kids who are actually receiving care or not. And so this type of information would provide sort of incredibly important information about the receipt of care for need and can provide some information about unmet need in the population. And so, given these evidence gaps, say we want to start building something. And we want to build an ability to measure these indicators. Well, we might start with developing a population health surveillance framework and outlining some of the key components that are related to data and measurement and analysis that would be used to estimate these indicators. And so myself and Kathy and others came together to develop one of these surveillance frameworks. And I'm not going to get into details on it because it would take forever. So today I'm going to talk a little bit about three key foci related to this, related to the development of a surveillance-related framework. And so first I'm going to talk a little bit about data. I'm going to focus most of my time on data because it's what I like thinking about. Yeah. And so when I think about data, one way in which I think about data is thinking about how it's relevant to our interest in our population of interest or a target population. So we can think about this green circle as an indication of all children and youth in our country for which we want to deduce some information about related to their health status. And this red dot shows that our estimates suggest that roughly 15 to 20% of this population may have a mental disorder at any given time. And this type of estimate comes from, the Ontario Child Health Study, whereas we know that we can't really measure this at the national level at this time, but this provides a good estimate. And then we can look to see what gets covered. Perhaps this is a hypothetical figure, but it shows that, general population surveys do a really good job of capturing the total population of interest when sampling is done robustly. And also it does a really good job of capturing a large proportion of the population who have a mental disorder. And this is because it's not determined based on the health status of those children and youth. And so I'm going to elaborate a little bit on some of the strengths and some of the challenges of using survey data for measurement. So survey data, to remember, is designed for research and policy in mind. And because of that, it has a number of key strengths. It can be used to develop representative samples of children and youth from the general population, irrespective of health status or service contact, as prior mentioned. It can also provide some broad coverage, conceptual coverage of the population, including key sociodemographical and health status and functioning indicators. And it often includes indicators of mental health services provided by non-physician services as well, including contacts with social workers, psychologists, and private practitioners. And this type of information is particularly key for trying to understand child and youth mental health. Some of the limitations of working with survey data is that it can be subject to information biases. And so it can we understand that recall bias and telescoping bias can have some challenges. It's really hard to remember where and in which settings you received care and the frequency in which you received care. And there's countless studies that have shown this, that it's really, really challenging to remember these things. And so that needs to be taken into consideration when we're asking questions to participants in surveys about, the services that they received. It might be hard to know exactly and triangulate exactly where they received care and for what sometimes. And surveys also might be subject to selection biases that cannot be eliminated through survey weighting and other procedures. And so in the figure on the right, you can see that there's a gap that remains between the green and the yellow. And this is the fact that we can't sample, the surveys don't sample on everybody and sometimes miss key components of the population. And so that needs to be taken into consideration as well. There's also sample size limitations from survey data, particularly when we're thinking about trying to estimate or deduce information from those with severe mental illness. There's respondent burden related to completing survey data itself. And then also survey data can underrepresent select group populations living in institutionalized settings or people with experiencing homelessness. And this is might also lead to differential involvement in the survey, which could lead to selection bias. And so all these concepts are related. But there's one really unique strength of survey data that I think that needs to be reflected on. And that survey data is really the only method of identifying all children and youth with a mental health related concern who have not received any or experienced barriers to receiving care. This is an incredibly important indicator if you think about it in the grand scheme of things. We need to know not just who are receiving care for mental disorders, but who are not receiving care. And we've kind of leveraged the strength of this type of question in survey data in a recent paper, also published in the Canadian Journal of Psychiatry, where we looked at provincial and territorial variation in barriers in accessing healthcare for children and youth with mental and neurodevelopmental health concerns. And for this study, we used the Canadian Health Survey on Children and Youth, which is a survey that we coined the CHEESY. And this provided a nationally representative sample of 47,871 young people between the ages of 1 and 17 as of January 31st, 2019. So this is using the 2019 data. And our objective here was to quantify barriers to accessing healthcare across Canada. And the key methodology that we used from the survey was the fact that the survey had questions that asked parents of children and youth who noted that they required or received services for mental or neurodevelopmental health concerns. They were further asked to characterize whether they experienced any barriers to care, and then define a little bit more about the types of barriers that they experienced. And so we use this question and this information to deduce whether there are differences provincially in barriers to care across Canada. And our findings did suggest there was significant variation in specific types of barriers between provinces compared to the national average. And we feel as though this type of work can be paired with some future policy mapping to help understand and inform policy development and evaluations across Canada. And we also feel as though this type of work, when followed up with future barriers, future information that provide information on barriers, we can start to test whether differences and changes in policy across the space can influence these barriers over time. And then we can hopefully try and triangulate on areas that are doing a really good job and have reduced barriers, and we can leverage the policies that are in place in those regions. Yeah, and then so next I'm going to talk a little bit more about population health administrative data. So raise your hand if you're familiar with administrative data. Cool, that's good. Okay, so administrative data is data that we use it's a byproduct of the healthcare system. So I'll try and give a good example of what this type of data provides. So everybody, most likely, people in this room have an OHIP card. Roughly 96% to 98% of the population have an OHIP card. And with that card is correspondingly, you have an OHIP number. And this information, with an OHIP number, every time that you receive care from a physician service, whether this is your family doc or a specialist or contacts in different types of care settings, but contacts with physicians, they write down your OHIP card number, and they also write down the reasons why you presented for that on that day, and then they also write down how much money they charge for that presentation. So all of this information gets gathered in this big longitudinal database that provides information about everybody and their presentations to physician services. And the reason this can be a robust way of measuring contacts with physicians is because they're motivated to get paid, which means that they're going to fill out these forms. And so that means we can deduce some information about the health status of the population using this information. So if we look at anyone's individual OHIP data, we can follow their trajectory and contacts with physicians throughout their life course, theoretically, if we have the data dating back to it. And then we use this information to understand trends and trajectories in healthcare services. For example, if someone has a hospitalization for mental health, maybe we have questions about whether they saw care from a family physician or an emergency department leading up to that hospitalization. These are types of questions that we can answer, using administrative data, which is this longitudinal data source that gets updated every 3 to 6 months, providing updates on the entire population with OHIP, for example, in Ontario. So that being said, this type of information provides a lesser coverage of the total population of interest, really because it's focused on those who are receiving care from physicians. And correspondingly, it theoretically has a lesser coverage of those with a mental disorder. As we know, among children and youth, for example, maybe roughly half of children and youth who identify with a mental disorder may not be receiving physician-based services for those disorders. And so we have to understand what these overlaps represent when we're using this data to measure mental health. So a little bit about some of the strengths of this data is that it provides ongoing near real-time coverage of services from physicians, and it can provide very large coverage of the population, for example, OHIP, which is a huge proportion of the Ontario population. It can also help alleviate things like recall bias regarding the timing and frequency and types of physician services. And so we don't have to ask everybody to remember every contact they had with a physician service. This would be noted in this data. Some of the limitations is that, once again, it only captures physician data, and there's no information on mental health services by other providers and non-physicians. And this is a huge gap, more for kids than it is for adults, honestly. So, and the idea that there's delays in treatment onset or there's a lack of treatment entirely can lead to underestimating prevalence when using these data sources in general. And this is something that you will see that, so I'm a fellow at ICES, and ICES report on the mental health of children and youth using these administrative databases. And you'll see that a lot of the targeting of these papers that have the largest impact relate to acute care setting contacts and hospitalizations, where health administrative data can do a really good job of capturing those with really severe mental illness. But when it comes to common mental disorders, as they present findings, they're really much more challenging to interpret because they're much more limited. And so we find this over and again. If you see health administrative data for children and youth on its own, and there's no linkage with some other data we'll talk about, it can do a good job for severe mental illness, but it's probably doing quite a poor job for measuring anxiety, depression, or less severe anxiety and depression, which still can be incredibly debilitating. So that's something to keep in mind. Also, there's traditionally limited information on sociodemographic mental health and functioning indicators captured from administrative data. Because you only have the primary reason for complaint that's captured in this data, we really don't know how well you're doing at that time. We just know you're presenting with anxiety or depression. And there's been advocacy for maybe collecting more data at the point of contact, but that's not currently existing. And then there's also a lack of standardization. And so we use different algorithms to try and deduce whether someone in the population has a disorder using this longitudinal data, but these are imperfect algorithms. So I will highlight briefly one of the unique strengths of admin data, and that's the fact that you can look at longitudinal course of life and lifespan perspective using this data. And I'm going to talk briefly about a project that's led by Kelly Anderson at Western University. And the goal of this type of work and she's developed, so also this is not published, so please don't share this information. So the goal of this work was to try and understand early life, the early life impacts of various environmental and social factors on future mental health of children and youth as they age. And so one of the first projects that's using this data source that's been derived from Kelly and her team was looking at socioeconomic trajectories throughout childhood and mental health service use during adolescence and early adulthood. And this was using a birth cohort that was developed using health administrative data. And so the objective of this work was to examine the associations between neighborhood income trajectories during childhood and subsequent health service contact for mental health and substance use disorders in adolescence and early adulthood. And the key methodology here was the fact that we used linked health administrative data to construct a retrospective birth cohort of children and youth between 1992 and 1996 in Ontario. And so one thing that to reflect on, one of the strengths of this information is that this cohort was actually derived from mothers. So we had information that connected mothers with newborns, and then we could follow the newborns over time. And so there's a data linkage called the mom baby database. And so because of this, we could actually capture all births between 1992 and 1996 that were included in this database. And then we could follow their children into a much older age. And one of the unique things about this is that we can also follow mothers over the same period of time. So we can have some information about mothers' contacts for mental health, which can help us understand perhaps some genetic predisposition to mental health. And we can also understand perhaps social, adversity for children and youth related to mothers' health conditions. And so these things become, expand the opportunities for the types of studies that can be conducted with this work. And so once, children and youth were born between 1992 and 1996, they were followed up to age 25 to 30 to identify outpatient physician visits and acute care visits to the emergency department and hospitalizations for mental health and substance use disorders. And so we use this latent class profiling to determine different childhood income trajectories so this is for kids between the ages of 0 to 12. And so we came up with a four class model where you can see on the top is the green represents sort of a stable, moderate, and high income trajectory for children and youth. The orange represents sort of a downward mobility where over time these children are moving from an area with higher level incomes to an area with lower level incomes as they get older. There's the opposite of that, the upward mobility group, who are moving from areas of lower income to areas of higher income over time. And then fourth, there's a stable low income group. And so once this is looked at between the ages of 0 and 12, then we look from age 12 to 25 to 30 to look at contacts for mental health. And we found that there was no significant relationship between these early life trajectories and outpatient visits, but there certainly was for acute care visits. And it's almost a dose response that was found, and a gradient effect for neighborhood income trajectory and acute care visits for mental health and substance use disorders, where we can see that essentially those who have more time spent in lower income periods, the older they get, the more likely they are in the future to have an acute care visit for mental health in the following years of their life. And one thing to reflect here as well is that I look at, like, you can reflect on the numbers that are included in these different trajectories. So the birth cohort has over 600,000 kids, and with that, you can start to explore strata that you really can't do with smaller sample sizes. Great. So now I'm going to talk a little bit about, I guess, the bread and butter of my postdoc work, which is talking about linked survey and health administrative data. So one thing we can do with data currently, and is currently available in Ontario and in other places across Canada, is individually link those people who completed a survey with their health administrative data records. So we have some information, some detailed information about these people when they complete the survey, and then we can also look at their health service contacts prior to completing the survey and following completion of the survey to help paint a broader picture of their health as it relates to mental health as well. And some of the strengths of this data is that it provides additional longitudinal follow-up from health administrative data to those who are completing the survey data. It also provides an addition of a broader coverage of mental health measurement, service use by other providers, and sociodemographical data for clinical populations. So if we're just thinking about trying to understand health status from health administrative data, if we have all this detailed information from survey data, it can really bolster our ability to understand what's going on in those health service trends. It's also like one of the only means of measuring alignment of population mental disorders and service use over time. And it can be used to potentially improve the accuracy of estimates of mental disorders in the population when information from both data sources are used at the same time to estimate disorder in the population. Some of the limitations of this work, it can be subject to linkage biases. And specifically, there's a few types of linkage bias, but one of them that we have to take into consideration is the fact that people have to consent to have their data linked when completing the survey. And so this can have an impact on who ends up being linked. Also, there's the linkage process itself is not traditionally a foolproof thing. There's a few methods to do this, but deterministic linkage procedures are a better way to do this. They actually like, for example, in the Ontario Child Health Study, everybody's OHIP card numbers were put into that survey, and they were linked with health administrative data using that code. And that's a really great way of linking, because you have a one-to-one match on numbers, or a close to one-to-one match on numbers, and that can provide a high linkage rate. So that's the ideal, an ideal linkage approach. And then it can provide some added complexity of analysis and interpretation of findings, and that just presents some more challenges for researchers to do a better job of communicating what the heck we're doing. So we've conducted a number of studies using linked survey and health administrative data. One of them was to try and characterize health service contacts for children and youth using both survey and health administrative data. And to do this, we used the Ontario Child Health Study. And now this is a representative sample of children. I don't really need to tell anybody here about the Ontario Child Health Study. I was looking around the room, I was like, oh, you all led it. All right, so it was over 10,000 kids aged 4 to 17 in 2014. But a little bit more about the linkage. 89.5% of the sample agreed to have their data linked, which is really quite high. And then we had 96.2% of them were successfully linked to those who consented to have the data linked. And our objective of this work was to try and understand mental health physician and non-physician contacts and their demographic and clinical correlates. And the key methodology here using the linkage was the fact that we estimated non-physician service contacts from survey data, and we estimated physician service contacts using health administrative data, where traditionally we would be relying on just survey data to measure both of these types of contacts. And then we looked at assessing clinical correlates, adjusting for mental health and need, which is another incredibly a powerful tool for understanding trends in health. When we have a measurement of symptoms and function related to mental health at a given time point, it can tell us a lot about the state of the population at that time, and we can use that information to have a much better understanding of trajectories related to service contacts, for example. So our findings were, after adjusting for total mental health symptom ratings and sociodemographical characteristics, we did find that older youth and youth from migrant parents were less likely to have contacts with both physician and non-physician services. And then children and youth with one or no biological parents in the home were significantly had a higher likelihood of coming in contact with these types of services. And our work does suggest that some of the greatest disparities may exist for children and youth with immigrant parents. And this provides a good example of how we can leverage both data sources. Now, I wasn't the first to use this linked data. The fantastic Laura Duncan was, and she's in the room. So I'm going to talk a little bit about some of the other studies that were conducted using this linkage to date, and then just highlight a few little lessons learned along the way and some of the questions that we have to fill going forward. So Lauren conducted this fantastic initial study looking at differences in estimating disorder using these different data sources in this linked file. And essentially, some of the lessons learned from this was that estimates of mental disorder and service use differed greatly between the linked survey and administrative data. And it posed the question, there's a lot of further work that's needed to understand who's actually been captured in these different data sources. And we've started to work towards trying to understand this, but there's still many gaps and there's still a lot of lessons to learn here. Jeanette Comeau, who's at King's College in London, Ontario, at Western University, did this fantastic work looking at correlates of acute care settings, correlates of children and youth receiving care in acute mental health care settings. And she showed that there's linkage provided this powerful platform for contextualizing children and youth presenting with acute mental health concerns to the emergency department. And as I mentioned prior, a lot of health administrative data focuses on acute care contacts. And so being able to elaborate on information that relates to who might be actually receiving care really was, showing off the power of this linkage. And then I did some other study where we looked at we sort of found that the ability to adjust for mental health need really starts to present some unique opportunities to look at health service trajectories over time and the patterns of contacts, and trying to understand whether certain contacts with some settings could perhaps change or alter or be related with other types of contacts in other settings. For example, we looked at whether youth with or without outpatient mental health services, whether that had an impact on future subsequent acute care contacts. And it was not related, but we can get it. We can talk about that further at some point. But it provides an opportunity to present new questions and enable new methodologies for looking at service trajectories. And then reflecting on using different data sources for measuring mental illness. Myself and Kathy wrote a paper in the Canadian Journal of Psychiatry, which kind of discussed using different data sources to estimate prevalence in Canadian settings. And in this work, we discuss the idea that to fully capitalize on the strengths of various data sources, us as researchers must conceptualize available sources as a collective rather than a series of sources in isolation. And also the idea that the strength of one data source may be its ability to reduce bias in another is really important. And so playing off one data source with another can have strong implications for our ability to measure these indicators of interest. And that while the technique used to combine data is important, we believe developing our theory of measurement is equally important. And so I'm going to reflect a little bit more on measurement now. So if we want to fill some evidence gaps, let's say that we want to measure the number of kids with a mental disorder, those seeing services, and then the misalignment of services. Let's just suggest these are some core starting indicators. Maybe we've talked with policymakers and we found that these are the right ones to focus on. And so we want to proceed by trying to estimate these. Well, we can make the arguments based on some of the strengths and limitations that we've kind of just gone through, that if we want to estimate the number of children and youth with a mental disorder, we should probably focus on using survey data as our baseline for understanding disorder in the population. And so, for example, if we use survey data, we could use parent and youth reported symptoms of mental disorders, and maybe we want to use the Ontario Child Health Study, emotional behavioral scales, and we want to initially start with some cutoffs to as they relate to perhaps the proportion of the population with a disorder. I know if Catherine Koss listening, she may not be super amped about that comment about trying to use cutoffs and binary indicators, but I'd like to sort of suggest that this is very much a starting point, and there's a lot of room for trying to understand those with varying needs over time, not just those with disorder or not disorder. I think it can provide a limited view of things, but it's a good starting point because it's easy. And given the fact that none of this is easy, we can, having a yes or a no, it can be a good way to start. And then say we want to estimate the number of people who are seen by service providers. And I'd argue that we'd want to use linkage for this, where we've shown that it's possible and it can be fruitful to use administrative data to estimate physician contacts and to use survey data to estimate non-physician service contacts. And then together, perhaps this provides an indicator of the actual breadth of services that are being contacted by children and youth with varying needs. And then if we wanted to think about the number with a disorder not receiving care, and this might provide some information about unmet need, we use a combination of these indicators where we can look at the discrepancy between those with mental health needs and whether they're receiving care or not. So let's say that we can do this using one survey data linked with administrative data. Using that graph, we can show the points of need, the points of service contact, and the discrepancies between them. That's all well and good. It gets a little bit more complicated when we're trying to think about this over time, when we're including different types of survey data to provide information about these concepts. So just for the sake of discussing what this might look like over time and providing some insight into potential approaches to conducting this work, let's think about administrative databases as these horizontal lines, survey data as these vertical lines, and then linked survey and administrative data as these connected lines. So T1 is representing sort of survey one at this time one period. And we've shown that, with what we just discussed, we show that we can measure these indicators using that data that's linked with administrative data. But what if we have a second survey and we want to start measuring this into the future? How can we do this work? There's a few ways to think about it, but this is one just a way to visualize how we might estimate these indicators. So on the y-axis, we can see prevalence here, and on the x-axis, we have time. So between time one and time two, this could be any amount of time. It could be a year, 2 years, 10 years, doesn't really matter. But let's say that we want to estimate mental disorder, and we say that survey data, we suggested that survey data is the best way to do this. So let's just make it easy, and we'll say we have some point estimates about mental disorder in the population using information from these different 2 points in time. And we'll just suggest there's a linear relationship of a steady increase or whatever the line is. But let's just suggest that it's just a slow and steady increase, though, of course, it probably relates to, there's probably variability over time. But anyways, next we want to measure the number who are seen by a service provider. And we know now from our discussion that this probably can come from a combination of administrative data and linked survey data. And so we need to take this into consideration when measuring these indicators, where we'll have periodic reports from administrative data because it's longitudinal in nature. But we need to know that this needs to be adjusted based on information from survey data. So let's say the adjustment from T1 is the adjustment from non-physician service contacts can be bolstered from the survey from time one. And we'll say that in the period closest to that survey, that'll provide information to help us understand what's going on in that period of time. And then when we transition closer to the second survey, let's suggest that that information is more relevant to us now, and we'll use information to help subsidize our measurement of services. And then the same can be said for unmet need, which is really built on a combination of administrative data and survey data. We can have some estimates of these need at periodic time points because it's a relationship between need over time and service contact. And there's going to be that interrelationship we can estimate as being, we can estimate at time one and time two, and then we'll say the period closest to that time will be led by survey data from that time. And then once again, as we transition to the second time period, that'll be informed by that second survey. So this is like I need to work on making this simpler. It's like, in my mind, I'm like, oh yeah, it's, whatever, we just throw in some data. It's like, it's not, yeah. So I think about this a lot, and I think at times I'll work on making this a simpler discussion. But essentially what we're trying to do is estimate these indicators over time, and we want to use the best data that's available over these periods of time. So we want to use the best survey data at this time period and the closest data to this time period. And then once again, when second survey comes, we want to start using that data because we think it's going to be more accurate. So we start to paint a picture and trying to fill in this puzzle using the data that we have available to us. And one key concept throughout this work is that when we're thinking about data and our ability to measure these indicators over time, the further we are away from a survey time point or like a really good data collection period, the more uncertainty we're going to have. And so I think this needs to be sort of thought about and built into all measurement of this, where if policymakers are trying to estimate mental disorders in between T1 and T2, for example, we know that this is going to be the highest amount of uncertainty that we have related to this data, and this needs to be reflected in confidence intervals or estimates or the way that we communicate what we're finding. Maybe we suggest we really don't know what's going on and we need more data and we need to advocate for that. And there might be a period of time where we can calculate where we lack so much confidence that we cannot, find anything related to this, or we stop. So this is so let's say we can measure, some core mental health indicators over time. Believe it or not, now the now the fun starts for me. But anyways, let's start thinking about these other data sources that we have available to us beyond just physician contacts and survey data. I'm gonna highlight a few different databases that currently exist or perhaps in the works, and kind of start to think more broadly about mental health and health that we can measure. So we have physician services. We know we've shown to use this, and we have census profile data. We know information about where people live and the neighborhoods in which they live. We can link tax data in the future. We can learn a little bit more about incomes at the family level. And then we've shown we can link in immigration data, where we can have some detailed information about immigration, not just binary indicators, but also like age of arrival and country from which you arrived, and migrant class related to whether you're a refugee or a family reunification migrant. So there's a lot more detail in that immigration data that we can link in. And then we could perhaps link in education and labor data, where we can have some understanding about contacts with secondary university settings and jobs, and those who are being employed. We can link in vital statistics to look at deaths. We can also link in really neat air quality and pollution indicators over time. And I'm currently on a grant application with a CAMH scientist, Marty Rottenberg, who's working to link in this air quality data to that birth cohort of 600,000 children and youth. And then we can link in information about green space and air temperature, gentrification, which relates to a database that provides some information about the changing in neighborhoods over time. Indicators of marginalization, which relate to socioeconomic status, but are much more in-depth and provide more perspective. Perhaps we want to link in COVID area level data, whether it's the disease itself or the policies that have been implemented related to COVID over time. And then the white whale out there might be actually trying to link in policy and programming data, where we can then start to think about evaluating these policies periodically. So let's say all of this is linked, and in one way or another, it can be almost. Most of it can be in the current space that we live in. And then the fun comes with, like, we have survey data, and these are linked to different types of data sources over these periods of time, and say this is a longitudinal study. How do we think about this? And there's another survey data. And then this is the puzzle that I think about all the time. So it kind of expands beyond just thinking about mental health, but it thinks about health much more broadly when you start to pool in all these different fun data sources. I think they're fun. And so this is the type of puzzle that I think about when I'm thinking about building surveillance one piece at a time. So I'll leave you with a brief discussion on a vision, and then we'll just hopefully get to some questions. But I think there's a need to build a surveillance platform in Canada, and that might take on a variety of forms. Maybe it's a housing of data, housing of dissemination, housing of interpretation or analysis. But there's a need to really develop a focus around this topic. And some of the priorities we might want to focus on for developing this platform is to establish best practices for evaluating and appraising and using Canadian data to inform surveillance and future mental health data collection. So I think we need to strategize the best approaches for using the data we currently have. And once we've done that, then we can suggest on how to use to collect data in the future to fill gaps. I think there also is a need to develop approaches to surveillance that are flexible and they best serve the needs of mental health policymakers and people with lived experience. And this is a incredibly important component of this, is that it needs, like, thinking about a platform needs to be something that's not rigid at all. It's something that's just adaptable. It's a space where people can ask new questions, build new comments, and contribute in new and different ways as the population changes over time. The whole point of surveillance is looking at change in health over time. The way that we measure this needs to also change over time. And we also need to build collaborative, cross-sectoral, federal, and interprovincial territorial partnerships to do this work. This really shouldn't be housed at one institution, but should be a collaborative effort. It's honestly the anti-silo of topics to talk about, where I think any siloed thinking on this really doesn't get you very far. And then we need to focus, I think we need to focus on transparency and principles of open science. And I know many others in this room do as well. And we need to make the methodology and the evidence that's produced from this surveillance in a living and open space that anyone can go access and understand. And there might be sort of different interpretations on the data that are easily deduced among people with different backgrounds. So I'm going to provide a little bit of a quick hypothetical about what might be able to be done in the future using surveillance data if we instill surveillance data into a mapping tool, for example. So let's say we have this linked data and survey data, and then we've combined it to have some understanding of health and mental health regionally over time. And then we can use this to identify spatial and temporal hotspots as they relate to mental disorders and perhaps other health conditions. And then with this linkage, we need to think about the fact that we don't really need to just focus on mental health, but these linkages really help us provide a focus on broader child and youth health in the population and their relationships with mental health. So for this hypothetical, this is very hypothetical. This is not real data, but let's suggest we find a hotspot in the Hamilton and Burlington region, and we find that there's a temporal hotspot for anxiety among children and youth in this region compared to adjacent regions like Milton or Flamborough or other regions that are adjacent to us. And let's say that we also find that in these areas, we're able to look at other types of chronic conditions, and we see that children and youth who are also with anxiety are more likely to have a chronic asthma in this region, and that these relationships are much stronger in this region than in other regions. And then we start to ask a question, what environmental factors might be related to asthma, and they might be related then tangentially to anxiety. And so we use some environmental data, and we find that maybe in this area there's some elevated pollutants in this hotspot region in this particular time. So now we have some information about some environmental factors, some health factors, and related health factors. And then we continue to dive further. And we understand that maybe that actually these estimates are differential based on the income of populations in these hotspots. And then we can start to think about, okay, maybe clinically we consult with clinicians and we realize that there's some new asthma med and it's really expensive. And only some families perhaps are accessing this asthma med. And maybe it relates to the fact that those on this medication don't need to worry about asthma attacks and have lower anxiety accordingly. And so because of this, we know that maybe there needs to be some sort of local initiative that's conducted. So we raise these concerns to local policymakers who can use this information to support the development perhaps of health outreach programs for asthma specifically, and maybe try and advocate for this medication to be readily available to populations. And maybe this is done through schools or other means. And then some time passes, and then we find that in Canada more broadly, things are changing. Maybe there's new policy updates on allowable pollutants in a region, and maybe this has an impact on certain factories in these regions, or the transit system we have, because we have one of the busiest highways in the country that's right through both of these places. Maybe these things change a bit. But the power here is the fact that we had this data platform to begin with, and we were able to identify this hotspot. We can go back to look at whether there's differential impacts of these larger policies in these regions where we showed, keying in on the relationships that we found between asthma and anxiety, and we can test to see whether there's effect of these policies. And so that's sort of one of the big ideas here, is that it's a multifaceted approach to looking at health in the population, and it may have some real world implications for policy. So surveillance is at the heart of our understanding of health conditions and is key to informing policymakers as they address population-based needs. And I believe it's time to prioritize child and youth health in Canada by investing in developing and sustaining continuously enhancing a robust mental health surveillance system that's developed explicitly for children and youth, taking into consideration the key factors that relate to child and youth health. So I'd like to thank my postdoc supervisor, Kathy Georgiadis, and all the collaborators on these projects and mentors over the years. This is very much not me thinking. This is very much a collective of ideas that I've had conversations with brilliant people over the last 10 years or whatever. How long have I been? I guess 3 years of postdoc, but university 10 years. I don't know. So quite a while. Anyways, and so I'm just really glad to be here and be able to chat about these topics with all of you. So thank you so much for taking the time. Thanks.